very, very high level in neurology and radiology in France. So when I bring people from France, usually I ask residents and fellows who I should bring, especially when it's not an MSK and I don't know people. Let me tell you that this person has the widest fan club in residents and fellows in France. So I'm so happy you could join us this year, and I hope you can come back. So thank you, Damien, for being with us.
And the organizer for inviting me here. It's really a pleasure and privilege to talk to this very nice meeting. The two talks will be quite asymmetrical. The topic will be the imaging of comatose states. So in the first part, I will just show you how to best image these patients, which are very often very difficult cases, both in a clinical and psychological point of view. And the second part will be much shorter, and I'll talk to you about the kind of database we are building to more reliably study this patient and try to perform research on these kind of situations. So persistent comatose states are quite a common disorders, and you have three main etiologies: cardiac arrest, traumatic brain injury, which are the two topics I will address, and all kind of brain bleeding, maybe subarachnoid hemorrhage or intracranial hematomas. The huge problems clinicians are facing that the evolution is completely unpredictable at the acute phase. And for exactly the same clinical setting, same patients, some will evolve toward restitution ad integrum, some will keep a moderate handicap, others will have a severe handicap, and all this is to be a huge social and economical burden on the society and very, very complex ethical problems. Traumatic brain injury, so what do we call severe traumatic brain injury? It's a traumatic brain injury requiring hospitalization in an intensive care unit. So it's a very common problem. In the United States, it's 275,000 hospitalizations a year of severe and moderate trauma, 52,000 deaths. It's the leading cause of death and handicap in young males, and the cost for the US economy has been evaluated to $70 billion each year. It's probably the case where the evolution is the most unpredictable case, unpredictable one. You have patients arriving with exactly the same Glasgow Coma Scale status. Some will evolve toward complete recovery, others will stay for years in persistent coma or vegetative state. The problem we have is that we have no treatment directly addressing trauma. We can keep the intracranial hypertension at bay, we can just evacuate hematomas, but we have no treatment directly curing the traumatic brain injury. Cardiac arrest, even more patients, usually older, 450,000 cases of cardiac arrest in the United States each year, more than 90% mortality. It's one of the leading causes of death in the developed world. We have a treatment. Recently, hypothermia has been developed, so what happens that the patient is rushed is you perform the cardiac massage, defibrillation if necessary, you rush the patient to the hospital, they start what they call hypothermia, so they lower the body temperature, and this has been proved to reduce the handicap of the patient if the patient survives. We had previously clinical and EEG prognostic factors, so we have very clear rule to manage this patient. They know when they should keep on reanimating them, or on which case it's really not necessary. We have about 48 hours during which the patient is under hypothermia. We cannot evaluate them at this time, but then the evaluation starts. Diffusion imaging has shown promises, but lacks sensitivity and has significant variation in procedures. So, what do we consider a favorable and an unfavorable outcome? So, we use a modified version of the Glasgow outcome scale. The Glasgow outcome scale is not the Glasgow coma scale, it's just to evaluate disorder of consciousness, let's say. It's a very basic scale. 1 is the seized patient, 2 is a vegetative state, 3 is considered severe handicap, but we have really separated the level 3 in 2 parts. 3 is heavy handicap at the level of consciousness. The patient is what is called minimally conscious, meaning that you think that the patient is present. The family thinks that he is with them, but you can't have meaningful communication with him. So he's not vegetative, he's, let's say, partly conscious. We have the other kind of 3 is to have a severe handicap, to be hemiplegic or aphasic. So in this case, we consider that as a favorable outcome. 4 is autonomous with a handicap, and 5 is fully normal. So if the patient is going to be 1 or 2, most people consider that going on with intensive care is really maybe not necessary. 3 is a very complex and ethically very, very difficult problem, and 4 or 5, of course, you must go on and do whatever it takes to just get the patient to emerge from coma. So why are these subjects comatose or vegetative? We have 2 main mechanisms that can explain the prolonged coma status. First is extensive cortical lesions. Second is lesions of the deep brain structures. Then we have lesions of the brainstem. And you can have a diffuse involvement of all these structures. Cortical lesions may cause a coma only when they are very extensive. And what you should evaluate also if they are bilateral and symmetrical, because we will see in the second part that it's one of the very important points conditioning the possibility of recovery. And you should also check for the involvement of functionally important areas. If the patient has bilateral destruction of the hippocampus, for instance, he will have to So you have to take that into account when you discuss with the family and decide what to do with the subject. If you have destruction of Wernicke or Broca area, he will have aphasia. So that's also a point to take into account when you evaluate these subjects. Prolonged cardiac arrest, deep comatose state. As you can see, you have massive ischemia of the cortical lesions. So this patient has no more kind of effectors, and all the cortical regions are severely damaged. So he is comatose because of this huge cortical involvement, and the probability of recovery in certain cases is, of course, very low. Lesions of the deep brain structures. The most important one to evaluate is the thalamus, and especially the posterior and internal part of the thalamus, what we call the pulvinar. It's more important than the striatum. Striatum is involved often in ischemia, but the thalamus, you have a very specific way of destroying the thalamus. When you have temporal lobe herniation, you will have a compression of the posterior cerebral artery, and in this case you get ischemia of the thalamus. And this is a very severe lesion. When you have bilateral destruction of the posterior thalamus, this patient will stay in a comatose, vegetative or minimally conscious state. even a unilateral lesion of the thalamus is extremely important to notice, because in this case, most patients will recover consciousness, but very often it takes a very long time. It takes weeks or months before your patient emerges from coma. That's a patient who had a head trauma with temporal lobe herniation. You had compression of the posterior cerebral artery with this ischemia of the posterior thalamus, and you can see that you have mirror lesions of the temporal lobe and brainstem. So you had temporal lobe herniation, compression of the posterior cerebral artery, and ischemia, bilateral ischemia of the thalamus. We followed this patient. He stayed vegetative for really years, and that's a guy who stayed about 3 years in the neurosurgery department before they were able to find him a long-term structure to care for him. Brainstem lesions are very important to evaluate. They can arise from direct trauma, deceleration, or ischemia. What happens that when you have a high kinetic trauma, the posterior fossa is, the brainstem is quite a very tightly packed structure in the posterior fossa, while the cerebral hemispheres are heavy structures with a kind of possibility of mobility. So when you have deceleration, the brainstem is kept very well packed in the posterior fossa, and you have this kind of motion of the hemisphere. In this case, you get lesions in the mesencephalon and superior and posterior pons. You have a kind of shearing and diffuse axonal injury in this region, and what is very important because what you have is a substantia reticulata. The substantia reticulata is a kind of pacemaker for consciousness. So you will either destroy the substantia reticulata or cut the communication between the substantia reticulata and the thalamus and the telencephalon. And typically, that's the kind of patient who may arise from coma, but will stay vegetative or minimally conscious for a very long time. When you have this kind of lesion of the posterior pons, middle pons and posterior pons, we know that's very severe lesion with a very high risk of lack of recovery of consciousness. Brain suffering in trauma, that's why you can't perform your evaluation very early. What happens that when you have a traumatic brain injury, you have brain edema. Brain edema increases intracranial pressure and will add to the primary diffuse axonal injury. Don't forget that this patient may have polytrauma, so they may also suffer from hypovolemia, and this further increases the insult on the brain. The problem that this kind of injury, you don't see it on conventional sequence. You know that it's very difficult to really evaluate the brain edema, even a CT scan. On MRI, you just can't bring the patient to the MRI when you have brain edema, you have increased intracranial pressure, you make the patient lay down on the MRI, you just keep the patient, because the first treatment is to just raise the head of the patient to reduce the pressure. So we do the evaluation when this ICP has resolved. So to evaluate this diffuse injury, we will use mostly 3 sequences: MR spectroscopy, diffusion tensor imaging, and we have some research study with functional MRI, but we will see that it's not a very good sequence to evaluate this patient. So MR spectroscopy, you know that it studies brain metabolism. We perform a single voxel acquisition on the pons coupled with a chemical shift imaging at the level of the basal ganglia. So you transfer everything to your post-treatment station, and then you will measure N-acetyl-aspartate, which is a neuronal marker, particularly in the cortex, thalamus, lenticular nuclei. The NAA-creatine ratio on the deep brain structure is about 1.5, 1.7. We know that when the NAA goes below creatine in a diffuse way, if NAA is below creatine in both thalamus, the this is a sign of severe and usually irreversible brain suffering. Diffusion tensor imaging, which is really certainly the most important sequence of all. Catherine talked to you about isotropic diffusion. In diffusion tensor imaging, you study anisotropic diffusion. You will have both diffusibility information and directional information. The principle that the water molecules in the white matter tracts are kind of canalized by the white matter tracts. So, when you perform diffusion tensor sequence, you will extract three parameters. The mean diffusibility is the global ease of diffusibility. Is the diffusibility much constrained or not much constrained? FA is how overall is constrained the diffusibility. Can the water molecule diffuse in all directions, or do they have a preferential direction of motion, which is in the white matter of the white matter tracts? But this results from the combination of two information, which are L1, which is the great axis of diffusibility, the direction on which the water can the most easily move, and this is, of course, the axon and dendrites. And we also have the smallest direction on which the water molecule can move, and this water molecule will be constrained by the myelin sheets. So L1 will give you an idea of the viability of the axons. LT, or you sometimes see L square, will give you an idea of the integrity of the myelin sheets. And this is hugely important because we will see that between traumatic brain injury and cardiac arrest, you have completely different pathological process at work, and these will affect completely differently L1 and LT. Resting state, fMRI, it excites a lot our neurologist friend. We don't use it much. Why? Resting state fMRI is fMRI without activation. So you just launch your fMRI sequence and just wait 10 minutes, stop the sequence, give the data to the neurologist. Do whatever you want with that. In fact, we don't use it. Why? The principle is quite, let's say, fashionable. We know that when the brain is fully organized, you will have brain regions working together. When brain regions work together, their blood flow will be synchronized. So if we can detect synchronization of blood flow, that's perfect. The brain is organized and works pretty well. So they have identified these kind of networks. And the problem we have is that to perform the MRI, you have to sedate the patient. When you sedate the patient, you decrease this variability in blood flow first, and we don't really know what sedation does to these networks. So, okay, in theory it's very interesting. They do very nice studies on vegetative patients. At the acute phase, we don't consider that really reliable. So you get this kind of very beautiful red spots over the image with this kind of coherence table. That's really great if you want to publish a paper, but to care for the patient, not that useful. So, how can we use diffusion tensor imaging and MR spectroscopy to study this patient and determine if they have a chance for recovering consciousness? So, but you have to understand that the mechanism of consciousness are still very imperfectly understood. What is known for sure is that we have a kind of impulse starting from the substantia reticulata, going through the mesencephalon, especially its posterior part, to the thalamus, which is interconnected with hypothalamus, basal forebrain, and all this is connected to the cortex. So with MR spectroscopy, we can study the substantia reticulata, the thalamus, and the cortex. With diffusion tensor imaging, we can study all the white matter tracts interconnecting these regions. So, in theory, DTI and MRS, especially combined, may help you determine if the patient has a chance of regaining consciousness or are these networks intact or not? Are they destroyed? So in theory, these sequences are adequate to evaluate these subjects. The problem is that, do we really have this information? Can we just get past the normalization problem, the distortion, etc., etc.? That's why we started these studies. So we have a patient with a severe TBI, outcome. This patient never gained consciousness. As you can see, as compared to a control, this patient has huge destruction of the white matter. The FA is diminished everywhere. We have massive destruction of the white matter tracts. Another case, a severe TBI with good outcome. The lesion look quite impressive. You have cortical contusions, some bleeding in the cortex, some T2 star, but you can see the FA map is not normal. This guy recovered with nearly no sequence. So you can see two very severe cases. This patient arrived at the ICU, globally in the same clinical status. One has massive destruction of the white matter, the other one has a really normal white matter. 26 years old, severe TBI. This guy regained consciousness but has huge neuropsychological impairment. He's not autonomous. He will never be autonomous again. He's in a center for vegetative for minimally conscious patient. He talks a little bit, but he's unable to do anything. If you look very rapidly to the image, the brain looks normal. But look at the size of the sulci and the ventricle. This guy is 26 years old. If he were 90-year-old, we would say it's a normal brain, but not for a 26-year-old. He has massive loss of parenchyma, despite a normally appearing MRI. Now look at the DTI, normal one. This patient, you have massive loss of fractional anisotropy in the frontal lobe. So this guy, despite a nearly normal looking MRI, had prolonged intracranial hypertension with a global loss of white matter. And even in spectroscopy, you can see that NAA, which should be around here, is really markedly decreased. So with DTI and spectroscopy, you can both quantify the white matter destruction and detect white matter involvement where you can see nothing on the conventional sequence. Other case, the image was pretty impressive. It was a woman who was assaulted at an ATM. So when you first look at the image, you say, okay, it's catastrophe. Huge hematoma in the temporal lobe, bilateral temporal herniation. But if you look carefully at the image, the lesions are asymmetrical. If they are asymmetrical, it means that you have one side has a way of compensating for the other side. Second important point, the hypocampi are completely normal. The brainstem is normal, you have no sign of ischemia in the thalamus. So look at the DTI, you have disruption where you have the hematomas, but the brainstem is completely normal on the DTI. So this lady spent 2 months in the ICU and 1 year later came back with her children to just say how happy she was to be alive and with nearly no sequelae. So you see that despite very impressive lesions, patient and increased ICP and brain herniation, patients can still make it. We just have to know if it's likely or not likely. Cardiac arrest, the images are much easier to interpret. 15 minutes of low flow, you have this lesion of the corpus callosum, caudate, cortex, lenticular nuclei. On DWI, massive high signal of the gray matter, and even of the corpus callosum. The most severe cardiac arrest will give you not only lesion of the gray matter, but also the white matter. And you already have impoverishment of the white matter tract. So we know that this guy is going to stay in a vegetative state if you go on and keep reanimating him. Another case, a 20-year-old who was on a stroke contraceptive contraception, and there was at this time a big discussion in France because they say that yes, the pills give pulmonary embolism. Okay, we know that, but we don't know this time made the news. This young lady collapsed in front of the family, say, oh, she must have pulmonary embolism. So they immediately called the first rescuer who arrived. She was in cardiac arrest. 1 hour external cardiac massage. Then they rushed her. They were massaging her. While rushing her to surgery, they performed what is called the Tredelenburg procedure, which is a thoracotomy. For 1 hour, they pumped the heart while the guy were removing clots in the pulmonary. Okay, that's crazy. She will not done it, but look at the MRI. It's completely normal. So the clinical history looks like a catastrophe, 2 hours of cardiac arrest, but a really good response and a very rapid cardiac massage. This lady, she was just complaining of the pain of course she got mediastinitis and thoracotomy, but otherwise she was completely normal. So 2 different cases, you can see that can help you say, okay, this was extreme intensive care, but still the patient has no lesion. We can go on. It was extreme intensive care, but the brain is completely destroyed. Have to warn the families that it's probably going to get nowhere. Okay, that's radiology 3D images. That's not something rational, that's not something coherent. What's going to happen if Damien reads the image? Will I have a different diagnosis than if Catherine reads the image? So we have to get rid of the inter-subject variability because it's a very passionate debate and people will tend to see the image as they want to see the patient. So to get rid of that, we started a really prospective evaluation of this subject. We have quantitative information. If we have quantitative information, we can use that to make a system helping you to reach a diagnosis. We started in Salpêtrière in the year 2000, so nearly now 16 years ago. The first study that we did was on TBI patients. We were lucky, we had 40 severe TBI patients who had a multimodal MRI. Half of them had a favorable outcome, half had an unfavorable outcome. We also included first controls to see, just kind of normalize, but we didn't need normalization this time. We just were curious to see that the severe patient had lesions or no lesions. We performed the analysis of spectroscopy and of DTI. And that's one of the residents, Eleanor Tollard, who just took this 40 examination and drew region of interest on the cortex, white matter, thalami, lenticular nuclei, external capsule. Then she drew region of interest in the different various white matter tracts. So it was a huge work, achieved something really very nice. And as you can see, these 40 patients, when they arrived at the ICU, these are the patients with unfavorable outcome, these are the patients with a favorable outcome. They had exactly the same initial Glasgow Coma scale on arrival. They stayed the same duration of the ICU, same duration of assisted ventilation. So it shows you that clinical information is completely worthless for me. The MRI was performed exactly at the same time, on average 3 weeks after the initial insert. They were so severe that we could only put them in the MRI 3 weeks after the trauma. When you look at the spectroscopy, that's the NR creatinine ratio on the bones and the average of the DTI on the posterior fossa and on the hemisphere. That's just the average of all the measurements we take. You can see that patients with unfavorable outcome had much lower FA value than patients with favorable outcome, both on the posterior fossa and on the hemisphere. They also had a lower NA ratio than the patient with favorable outcome and then of the controls. Same thing for spectroscopy in the supratentorial region. So, okay, that's statistically correct. Now you have to use a multivariate, what is called a multivariate analysis. What is this principle is that you just take all your data, put it in a kind of computer system and say, okay, do whatever it takes to separate at best the population. Have you got enough information just to reliably tell me this patient is going to have a favorable outcome, this patient is going to have an unfavorable outcome? And as you can see, we separate very nicely by this combination of information, patient with an unfavorable outcome from patient with a favorable outcome, and these patients are completely separate from control. That's very severe trauma, so even when patients make it, they still have significant destruction of the white matter. So that's very nice. We can say we can separate this population. Good. But there is still two huge big caveats. The first one is that it's a statistical information, meaning that this patient, the system tells you, he will have about 90% chance of having a favorable evolution. This patient will have a 90% chance of having an unfavorable evolution. So you still have statistic uncertainty, and of course you will not want to tell things to the family if you will not say to the family, okay, it's gonna be okay, you still have 25% chance of having an unfavorable outcome. You will not tell the family, okay, say, okay, you will keep huge sequels if you still have 10 or 20% chance of having a favorable outcome. So that's statistical information. That's what we call kind of gray zone, and we have to reduce this gray zone. Second problem, Eleanor Tonala now is in Rouen. So we can just send her the MRI and tell her, okay, we study about 20 patients. Can you just draw these 20 regions of interest on spectroscopy, 20 regions of interest on DTI, and send me back the information. So there is some kind of manual and observer variability inherent to this kind of study. So we have to automate the process. So we process on the DTI on the same patient, and we use what is called voxel-based morphometry and fact-based spatial statistics. I will not dwell into much details about this process. What we do is that we take the DTI acquisition, just correct everything, normalize it on what is called the Montreal Neurological Institute Atlas, and get some kind of a normalized brain for each patient. And then we take the patient with favorable outcome, we take the patient with unfavorable outcome, we take the controls, and we search for group difference among these patients. That's a pipeline. That's basically the one we are still using with kind of refinement, and you'll see the second part. When you take the patient with favorable outcome versus control, what you can see is that the differences are located essentially in the frontal lobes. So patients with a severe trauma will differ from control by lesions in the frontal lobe. It's extremely interesting because it's exactly the same kind of lesions you will find in patients with so-called moderate trauma and with some kind of post-concussive stress disorder, or these patients were considered, let's say, like it was called linked to post-stress, post-trauma depression for a very long time, till we started doing MRI to the subject, and it has been shown that these patients with this so-called post-trauma stress disorder, post-trauma depression, in fact, have lesions in the frontal lobes. And so the patient with very severe TBI and favorable outcome just are very close to the patient with moderate trauma and sequelae. So patient with unfavorable outcome as compared to control, you can see that you have a massive lesion everywhere in the brain, but what's interesting is not comparing patients with unfavorable outcome to controls. We know they are not controls. It's comparing them to patients with favorable outcome. And what will give you an unfavorable outcome? So it's not the radiology convention, it's let's say, physicist convention, meaning that left is left, right is right. You can see that this patient with unfavorable outcome will differ from the controls, from the patient with favorable outcome by lesions in the corpus callosum, left internal capsule, left temporal lobe. Now you can just pick up this region and make your statistic not on random region in the brain, but in regions really separating the patient with unfavorable outcome from patient with favorable outcome. That's what we did. That's the difference you observe. That's controls, patient with favorable outcome, patients with unfavorable outcome. So you can see that the differences are of course maximized because you just targeted your analysis on the region significantly different between patients with unfavorable outcome and patients with favorable outcome. Like that, you get, we fix a 95% sensitivity. And in this case, you get a 50% sensitivity for 97% specificity, meaning that for about half patient, you can say with a near certainty that the outcome is going to be favorable or unfavorable. So for half patients with TTI alone, we didn't use spectroscopy, just on analyzing TTI, you can say if the patient is going to make it with no moderate major sequence, or if he's going to stay vegetative or minimally conscious. The problem that this study was done only in Pitié-Salpêtrière Hospital. So it was done on one machine in one hospital. If you want to be reliable, you have to say that 80 patients scanned in 80 MRI will have the same results. And for that, you need to take into account intermachine variability. That's why we started first a French study in 2005, so 11 years ago, has been funded by the French government. Then we received funding from the European community. And the aim of this study was to develop a way of giving the clinician an idea of the prognosis in the major cause of prolonged comatose states: TBI, cardiac arrest, subarachnoid hemorrhage. We included both DTI, conventional sequence, MR spectroscopy with quite low requirement for DTI. It was at this time on 12 direction, 3 millimeters isotropic voxel. We wanted all the centers to be able to participate. Like Catherine told you, you have had a huge project in the quality of the sequence you get. Back 11 years ago, it was really not the case, so we had to do this kind of, let's say, moderate quality data. And this is very important on an open access model, meaning that we keep the data. If people have an idea and want to use it for their studies, we make it available to them. What was developed first is a way of segmenting the white matter based on an atlas of white matter tribe that has been developed by Suzumu Mori at Johns Hopkins. So what happens is that you inject the MRI in the system, and the system automatically segments the white matter in 20 regions of interest. Another important point is that you have to have controls to normalize the information. These are the value of the fractional anisotropy measured in controls on the first machine included in the multicenter study. And that's the average FA value in these 20 regions in the control. And as you can see, you have huge intermachine variability. So you do have to normalize your information. You have to scan at least 5 controls to get normalized results. That's the values in patients with unfavorable outcome without normalization and with normalization. So we just take the FA value of the patient and divide it by the average of the FA in the control scan in this center. And as you can see, we get rid of intercenter variation. So what we get published on the 104 first TBI patients, including the study, 7 centers, 8 different MRIs. We can predict unfavorable outcome. So the aim was to predict unfavorable outcome with more than 95% sensitivity. We did a survey among intensivists and radiologists, say, what is the level of error you would personally consider acceptable? And the consensus was of a 5% error was considered okay. So we fixed the threshold at 5%. And as you can see, for the 2/3 of the patients, we can reliably predict the unfavorable outcome with more than 95% chance of not making an error. So the systems will give you a map of FA, so give you where the patient has lesions on a normalized map, meaning that you can perform the MRI anywhere. If you have controls, you will get exactly the same value. You can perform your MRI in Tel Aviv, in Paris, or in New York, you will get exactly the same maps. Then the system automatically extracts the FA, L1, LT, and D values in the 20 region in the patient, and will first plot it against the controls and the patient with an unfavorable outcome. Then we'll run it into the statistics method, what is called a support vector machine, to, at best, position it as compared to patients with unfavorable and favorable outcomes. So you can see 2 patients. This one has concussion of the temporal lobe. This one has multiple concussion, especially involvement of brainstem, corpus callosum. So this one has this FA map. You can see the FA map, which is normal. This one has a very disrupt FA map. And the first one has values very close to controlling the same region. The second one has values just falling well within the values of patients with unfavorable outcome. Then the system will position it as compared to patient controls, patient with favorable outcome, patient with unfavorable outcome. And as you can see, the first patient falls in the region where you have patient with favorable outcome and controls. The second one falls in the region where no patient had a significant clinical recovery. I will finish the talk by the kind of additional information you can get with these studies. That's a study that was performed on this data at the Mass General Hospital by Julian Lincoln, who was a fellow at this time in MGH. We just take the patient from the first study, the 20 patients with favorable outcome, and we ask them to come back. 15 of them accepted. And we scanned them 5 years, 2 years, and 5 years later to see what happened. Is the lesions that we observe are fixed? Can we have some kind of regrowth of neuron, or do we still have a neurodegenerative process going on? So that's the control scan at year 0 and year 2. So we can see that we have no variation linked to the, let's say, aging of the MRI. The values are exactly the same. That's the patient with favorable outcome scan during the ICU stay. And that's the rescan of this patient. That's the LT, the myelin destruction. As you can see, no, it's published. Sorry, in the AJ now. As you can see, this difference is the difference of the measurement between the patient's favorable outcome and controls during the ICU stay. The data I already showed you. But what is interesting is that we still have a process going on even after the patient exits the intensive care unit. We have a secondary neurodegeneration taking place up to 2 years after the initial insult. And that's hugely important because we have no treatment for TBI. And that means that we basically have 2 windows to try to treat this patient. The first one will be during the ICU to try to reduce the primary insult. And a drug efficient on this phase of the traumatic brain injury will basically lower this first line toward the controls. But we have a second window of opportunity to treat this patient, is to stop the neurodegenerative process. And in this case, this drug will lower this line toward the first one. So with this kind of approach, you can not only evaluate the prognosis of the patient, but you can also evaluate the potency of the drugs you are developing for TBI. I will finish by what are the differences between TBI and cardiac arrest. It's say basic, completely ridiculous, but if you take the studies of patients in vegetative state or coma, and you have a huge number of studies on this patient using functional MRI, DTI, PET, PET-MR, etc., etc., etc. And they happily mix patient vegetative or minimally conscious due to traumatic brain injury or cardiac arrest or even intracranial hematoma. But are these patients really the same patient? So in this case, we took the patient with unfavorable outcome and compared the patient with unfavorable outcome from cardiac arrest and from subarachnoid and from traumatic brain injury. That was work done by Anke van der Eerden, published in Radiology. And what you can see that patients with cardiac arrest with unfavorable outcome have mostly lesion in L1, and this lesion is symmetrical. That's a kind of a cut of the brain. In the center, you have the corpus callosum and the brainstem. At the periphery, you have the right hemisphere and the left hemisphere. And you can see that the lesion in cardiac anoxia is on L1 and is symmetrical. And you have the same involvement of the right and left hemisphere. When in cardiac arrest, you have very few involvement of L1. You have not that much axonal damage. When you take the MT, the myelin lesion, you can see that you have very few lesions of myelin in cardiac arrest, and this lesion is completely symmetrical. While in traumatic brain injury, this lesion is completely asymmetrical, like I showed you in the second study we did with VBM, and predominates in the left lobe. So people doing this study on vegetative patients or minimally conscious patients are happily mixing two very different pathologies. One involving mostly axon, symmetrical, cardiac arrest, and one involving the hemisphere, asymmetrical, and predominating on myelin, which is traumatic brain injury. As a conclusion, DTI can help predict clinical outcome of cardiac arrest and severe TBI with a good sensitivity and a very good specificity. I will show you later the results for cardiac arrest. They are borderline scary. Major limitation is in the intervention variation in DTI measurement currently requiring the inclusion of control. We have no reliable phantom for DTI, and a better understanding of the cause of this variation and development of DTI phantom would bring this to clinical routine. Thanks for your attention.
As you can understand, the next lecture Daniel will give will be within shorts, because he had to explain so much in the first part. Okay, thank you.